tonsil. What is palatine tonsil? Tonsils are bilateral ovoid mass. This is bilateral. Palatine tonsils are bilateral ovoid mass of lymphoid tissue on the lateral wall of the pharynx, occupying the interval between the anterior and posterior pillar of fauces. So tonsils are bilateral ovoid mass of lymphoid tissue on lateral wall of the pharynx, occupying the interval between the anterior and posterior pillar of fauces. Now blood supply of the tonsil. Blood supply of tonsil. Artery supply first of all, and then venous drainage. Main source of blood is tonsillar branch of facial artery. This is tonsillar artery and this is facial artery. So main branch is tonsillar branch of facial artery. Additional sources are ascending palatine branches of facial artery, then dorsal lingual branches of lingual artery, ascending pharyngeal branch of external carotid artery. This is external carotid artery, and this is tonsillar branch of ascending pharyngeal artery. In the greater palatine branch of maxillary artery. This is maxillary artery. This is descending palatine artery. Venous drainage. Blood drains. Veins from the tonsil drain into paratonsillar vein. This is paratonsillar vein, which joins the common facial vein. This is common facial vein and pharyngeal venous plexus. Next topic is tonsillar bed. Formation of tonsillar bed. The bed of tonsil is formed from within outwards. From within outwards, it is made up of pharyngeal fascia. This is tonsil and this is tonsillar bed. Pharyngeal fascia, superior constrictor and palatopharyngeus muscle, then buccopharyngeal fascia, then lower part of styloglossus and glossopharyngeal nerve. This is glossopharyngeal nerve. This forms the tonsillar bed. Classification of tonsillitis. Tonsillitis are of two types. Acute and chronic. Acute tonsillitis are four types: acute catarrhal or superficial tonsillitis, then acute follicular tonsillitis, acute parenchymatous tonsillitis, and acute membranous tonsillitis. This is the example of acute membranous tonsillitis. Then we will talk about the types of chronic tonsillitis. This is one of the example of chronic tonsillitis. Chronic tonsillitis are of three types. First of all, chronic follicular tonsillitis. Number 2, chronic parenchymatous tonsillitis. and chronic fibroid tonsillitis. Chronic follicular tonsillitis, parenchymatous and fibroid. Follicular, parenchymatous and fibroid. Follicular, parenchymatous and fibroid. This is the example of chronic tonsillitis. Talk about tonsillitis. Definition of chronic acute tonsillitis. It is an acute inflammation of the palatine tonsil. This is palatine tonsil, and inflammation of the palatine tonsil is called tonsillitis. Management of acute tonsillitis. First of all, we will talk about clinical features, then investigation, and finally treatment. Clinical features. Sore throat. First of all, sore throat, uneasiness or foreign body sensation during swallowing. As it is the enlarged tonsil, there will be uneasiness or foreign body sensation during swallowing, difficulty on swallowing, fever and earache. Signs: tonsils are red, swollen with yellowish spot of purulent materials. Then sometimes enlarged tender or jugulodigastric lymph node, jugulodigastric lymph node or tonsillar lymph node found. In short, palpable lymph node found in case of acute tonsillitis. Second step of management is investigation. Investigation includes throat swab. This picture shows taking of throat swab for culture and sensitivity. Second test, blood for total count, differential count of WBC and ESR. Treatment. The treatment includes the patient is put to bed and encouraged to take plenty of fluid, but to analgesic, aspirin and paracetamol. Number 3, antimicrobial therapy. That means antibiotic which are used in case of acute tonsillitis are penicillin, ampicillin or amoxicillin plus clavulanic acid. Penicillin, ampicillin, amoxicillin or amoxicillin plus clavulanic acid. These are the drug of choice. Patient allergic to penicillin. Patient who are allergic to penicillin can be treated with erythromycin. Antibiotic should be continued for 7 to 10 days. Complications of acute tonsillitis. Complications of acute tonsillitis includes chronic tonsillitis with recurrent acute attacks, peritonsillar abscess, retropharyngeal Parapharyngeal and retropharyngeal abscess, cervical abscess, acute otitis media, rheumatic fever, acute glomerulonephritis, and subacute bacterial endocarditis. Talk about differential diagnosis of white patches on the tonsillitis. Differential diagnosis of white patch. Differential diagnosis of white patches on the tonsillitis. These are membranous tonsillitis. This is the example of membranous tonsillitis. Then diphtheria, Vincent angina, infectious mononucleosis, agranulocytosis, leukemia, aphthous ulcer, malignancy tonsil, traumatic ulcer, and cardinal infection of tonsil. Chronic tonsillitis. Tonsil may show varying degree of enlargement. Tonsils are small, but pressure on the anterior pillar express frank pus or inspissated pus or cheesy material. And finally, non-tender bilateral palpable enlarged jugulodigastric lymph node. Same as acute tonsillitis. And investigations, thoughts of our culture and sensitivity, blood for total count and differential count of WBC, treatment, conservative treatment, attention to general health, diet, treatment of coexistent infection of teeth, nose, and sinuses, surgical treatment, tonsillectomy under general anesthesia. Malignancies of palatine tonsil. Malignancies of palatine tonsil, squamous cell carcinoma, then adenocarcinoma, lymphoma, and sarcoma. This is the example of malignancy of palatine tonsil. Peritonsillar abscess. What is peritonsillar abscess? The other name of peritonsillar abscess is quinsy. It is a collection of pus in the peritonsillar space, inflamed palatine tonsil with exudative spot. This is the collection of pus in the peritonsillar space which lies between the capsule of tonsil and the superior constrictor muscle. Tonsil and superior constrictor muscles. It is a collection of pus in the peritonsillar space. The peritonsillar space which lies between the capsule of tonsil and the superior constrictor muscle Management of peritonsillar abscess. Clinical features include fever. Symptoms include fever, and signs include severe pain in the throat, usually unilateral, odonophagia, muffled and thick speech, also called hot potato voice, and trismus. This is the figure of a trismus. sign. The tonsil is swollen. If we look at the figure, this is a tonsil of right side and this is the tonsil of left side, and it is swollen. Investigations include CECT or contrast enhanced CT scan. Contrast enhanced CT scan or MRI shows the abscess and its extent. Needle aspiration of an abscess provides material for culture and sensitivity of bacteria. Treatment: conservative treatment, intravenous fluid, systemic antibiotics, analgesics. Aspirin is avoided because of the danger of bleeding. Oral hygiene by hydrogen peroxide or saline mouthwash. Surgical treatment. Surgical treatment is incision and drainage under local anesthesia. Interval tonsillectomy. Tonsils are removed 4 to 6 weeks following an attack of quinsy. Abscess or hot tonsillectomy is done. Etiology of quinsy. Complications of acute tonsillitis arises de novo without previous history of sore throats. Bacteria responsible: 3 bacteria: Streptococcus pyogenes, Staphylococcus aureus, and anaerobic organisms. Mixed bacterial flora. Complications of peritonsillar quinsy. Parapharyngeal abscess, edema of the larynx, swollen vocal cords, edema of the larynx, septicemia, pneumonitis or lung abscess, jugular vein thrombosis, spontaneous hemorrhage from carotid artery or jugular vein. These are the complications of peritonsillar abscess. Now retropharyngeal abscess. This is retropharyngeal space, true retropharyngeal space. If we define retropharyngeal space, it is the space lies behind the pharynx. This is pharynx, and retropharyngeal space lies behind the pharynx between the buccopharyngeal fascia covering the pharyngeal constrictor muscles and the prevertebral fascia. Buccopharyngeal fascia and prevertebral fascia. This is the cross section of retropharyngeal space, and it is situated between prevertebral fascia and buccopharyngeal fascia. Contents of retropharyngeal space: only 2 components: retropharyngeal lymph node and loose areolar tissue. Types of retropharyngeal abscess: only 2 types: acute and chronic. This is retropharyngeal abscess. The definition of retropharyngeal abscess is: this is an abscess of true retropharyngeal space of gillette due to suppression of the medial group of retropharyngeal lymph nodes by ordinary pyogenic organisms. Etiology. The etiology of retropharyngeal abscess are suppression of retropharyngeal lymph nodes, This is retropharyngeal space, and suppose it is the lymph node. So suppression of retropharyngeal lymph node from nasopharynx, adenoid through eustachian tubes, penetration of the sharp foreign bodies in the pharynx, and bacteria Streptococcus pneumoniae is the commonest organism. Management of acute retropharyngeal space. Clinical features: difficulty in breathing as it is obstructing the airway. It will causes difficulty in breathing. Stridor and crappy cough and high grade fever. It is abscess, so it will cause fever. Signs include bulge posterior pharyngeal wall. This is pharyngeal wall, and this is the bulging of the pharyngeal wall. Investigations: only one investigation. X-ray or neck soft tissue lateral view. X-ray neck soft tissue lateral view. What we can see in the X-ray: widening of the prevertebral shadow. This is the vertebra, and this is the prevertebral region, and we get the widening of the prevertebral shadow, and possibly even in the presence of gas. Fluid level is seen. Then treatment. Treatment includes incisional drainage without anesthesia. No anesthesia. Through the oral cavity over most approachable bulging part. This is the most approachable bulging part. Precaution should be taken before incisional drainage. Always vertical incision, less chance of soft tissue injury. Strong sucker in the hand. There will be always presence of strong sucker in the hand, so that we can suck the blood and the pus. Head downward and turn to the surgeon. Good light source, and patient in supine position. Tracheostomy may be needed. If respiratory distress persists due to laryngeal edema. Complications are edema of the larynx, rupture of the abscess, asphyxia. Rupture of the abscess causes asphyxia, pulmonary complications, hemorrhage, and fatality. Acute retropharyngeal abscess and chronic retropharyngeal abscess. Acute and chronic. Acute retropharyngeal abscess is acute retropharyngeal abscess and chronic. Age of the patient in acute retropharyngeal abscess. Patients are generally infant and small children. Aged 1 to 3 years. And chronic retropharyngeal abscess occurs in elderly children and young adults. Space involved: space involved in acute retropharyngeal space is true retropharyngeal space of Gillette. True space. And chronic retropharyngeal abscess. In case of chronic retropharyngeal abscess, space involved is prevertebral retropharyngeal space behind the prevertebral fascia in front of vertebra. This is vertebra. Causative organisms, pyogenic in case of acute retropharyngeal space, and tubercular in case of chronic retropharyngeal abscess. Onset acute, and as TB is a chronic disease, and this the onset of chronic retropharyngeal abscess is chronic. Clinical features: dysphagia, it occurs in acute and it is chronic. Dyspnea, common in acute, uncommon in chronic. Fever, high grade fever, and low grade as it is TB. The features of TB, almost all the features of TB are found in chronic retropharyngeal space. On examination of pharynx, swelling of the posterior pharyngeal wall and midline swelling is found in chronic retropharyngeal abscess. Treatment drainage must in case of acute retropharyngeal abscess. In case of chronic retropharyngeal abscess, if necessary, through post triangle. Drugs, systemic antibiotics and analgesic. And in case of chronic retropharyngeal abscess, drug will want anti-TB drug. Anti-TB medications. Radiological features: retropharyngeal space enlarged. In case of chronic retropharyngeal abscess, it will be normal. Fluid level present, then absent. Spine destruction absent, but present in chronic retropharyngeal abscess. This is the figure of chronic retropharyngeal abscess, and these are the caries present in chronic retropharyngeal abscess. So spine destruction occurs in chronic retropharyngeal abscess, but spine destruction is absent in acute retropharyngeal abscess. Operation of tonsillitis. Chronic tonsillitis is tonsillectomy, and we do the operation in Rose's position. It is also called tonsillar position, in which patient lies supine, head is extended by placing a pillow under the shoulders. A rubber ring is placed under the head to stabilize it. Hyperextension should always be avoided. Tonsillectomy means surgical removal of palatine tonsil is called tonsillectomy. Complications of tonsillectomy operations. This is the patient position, Rose's position, and left lateral position. This is the recovery position. Of the tonsillitis. Of tonsillectomy. Complications of tonsillectomy operation. Immediate complications And then delayed complications. Immediate complications are hemorrhage, all types of hemorrhage, primary, reactionary, and secondary hemorrhage is the delayed complications. Then injury to the tonsillar pillars, uvula, soft palate, tongue, or superior constrictor muscles, teeth, or injury to the surrounding structure. Aspiration of blood, facial edema, surgical emphysema. This is the example of surgical emphysema. This is the example of surgical emphysema. Delayed complications are reactionary hemorrhage, secondary hemorrhage, which occurs after 24 hours of tonsillectomy operation. Infection, parapharyngeal abscess, otitis media, lung complications, scarring of soft tissue, scarring of soft palate and pillars, tonsillar remnants, and hypertrophy of the lingual tonsil. One of the immediate complications of tonsillectomy operation is reactionary hemorrhage. In reactionary hemorrhage, bleeding occurs within 24 hours. But commonly within 5 to 6 hours. Causes include failure to ligate the all bleeding points, slipping of a loosely tied knot, or clot following the rise of blood pressure after operation. Then collapsed vessels opening up in the post-operative period. Number 4, bleeding from vessels after relaxation of stressed facial tissue and muscle on removal of the mouth gag. Failure of vessels to contract and retract following crushing. In case of number 6 local anesthesia, as the effect of adrenaline wears off, the vessels dilate. Clinical features include dribbling of blood, vomiting of clotted blood, repeated swallowing, increased pulse rate, decreased blood pressure. Treatment includes, it is to be ensured that airway is clean. Airway is clean and there is no obstruction or hypoxia. Mouth is open and tonsillar fossa is inspected. If bleeding clot is seen, then it has to be removed with lug forceps. And swab is held firmly against the fossa for several minutes. If the clot is secure and no bleeding around it, the patient is kept under watch, keeping the pulse rate every half an hour. If the patient is fully conscious, a sedative is to be administered. If bleeding persists, and in case of child, the patient is to be taken to operation theater immediately and under anesthesia. The bleeding is controlled by ligation of bleeding vessels. The bleeding is controlled by ligation of the bleeding vessels. This is the example of ligation of bleeding vessels. A nasogastric tube is introduced before anesthesia and solid blood is to be sucked out to prevent aspiration. Blood transfusion, BT or blood transfusion, is necessary in severe cases. Secondary hemorrhage. any hemorrhages after 24 hours, any hemorrhages after 24 hours in the postoperative period is called secondary hemorrhage, but the usual time is on the 5th to 10th POD or postoperative days. Causes secondary infection in the tonsillar fossa and separation of slab. Treatment includes number 1, remove the infected clot or slab by long arterial forceps. Number 2, H2O2 gargle. This is the figure of hydrogen peroxide mouthwash. Systemic antibiotics should be changed what was given before and give high dose broad spectrum antibiotics. Number 4, sedative such as diazepam is given. Analgesic for relief of pain. Number 5, analgesic for relief of pain. Number 6, rest in bed. Number 7, is gauze piece. This is a gauze piece in the fossa soaked with H2O2. If the above procedure are failed, 24 hours will remain there. Gauze pack in between anterior and posterior pillar and 2 to 3 stitches over the swelling pillars are given under general anesthesia. Blood transfusion is necessary in severe case.